introduction, because nowadays the average pregnancy date, at least in metros, has moved to 32, 34, 35 years, not like before 25, 27, 28, they have completed the family life. So then the issue of fertility preservation comes into play. Number one, is there any way, even if you do a hysterectomy, ovary can be preserved? Number one. Or is there any way uterus conservation can be done until pregnancy happens and then you can go back and do hysterectomy? So to address this, we have very senior most gynec oncologist who has served in regional cancer center as professor of surgical onco and gynae onco, and now heading the academic division and department of gynae onco at Aster International Institute of Onco. And this is a very interesting topic. Please go through that. Any doubts, questions you have, please put it in chat box. In the last 10 minutes, Dr. Ahuja sir will open the chat box and answer all the doubts. Welcome, and over to you, sir. Thank you very much for accepting the invitation at short notice and keeping yourself free for the benefit of students. Welcome, and over to you, sir.
Yeah, thank you, Professor Somsekhar, for the introduction, my introduction, also introduction to the topic. So, as Dr. Somsekhar said, we are discussing endometrial cancer and why in young women, because endometrial cancer generally for all ages has the same standard treatment, but as discussed in the introduction, there are certain issues which are specific to young women. Now, generally, age, they say, is a function or a state of mind. The person is young as long as he feels he's young. But for the sake of our discussion, we take a young woman, a woman up to the age of 40 years. Okay.
So click once or twice. Or
yeah. Okay. So what would be our points for discussion today? I mean, we'll be all relating to the target group of young women, generally diagnosis and assessment. What are the options for fertility sparing treatment, and what are the things to look at for considering ovarian conservation and definitive surgery, and is there any role of hormone replacement therapy following treatment? So this is just to understand the magnitude of the problem. If you see this graph, one is the incidence rate, the straight line, and the number columns indicate the total cases. If you just see, if you can see my pointer, our target population is up to 40 years. It is a very small percentage of population, which is usually under 10%. But as Dr. Somsekhar said, we may see a rising trend. So we should be aware of all the issues which come up in this small population at present. So general comments on what happens, what is the presentation. This age group generally they have favorable histological type, that means well differentiated adenocarcinoma, or it may be an adenocarcinoma where the squamous coil component is benign and you have a well differentiated adenocarcinoma. Most of these invariably present with a uterine confined stage 1 disease. And if you see age for stage, the women, younger women tend to generally have a favorable prognosis if they have an endometrial tumor compared to older women. I'll just close. Okay. Now, talking about the presentation, as Dr. Somsekhar said, most of these women are usually have some form of infertility, and they are usually under investigation for infertility. And then during the workup, whenever an endometrial sampling is done, a cancer is diagnosed. Obesity with a BMI greater than 30 is responsible for more than 80% of the cancers diagnosed. This is a big issue because it indicates the lifestyle changes happening and greater incidence of obesity in our population now. The reason why obesity is associated with cancer is it may affect the tumorigenesis through insulin resistance, hyperinsulinemia, and localized inflammation. So there are various things which influence the pathway to cell proliferation and development of cancer in the endometrium. And if PCOD, that is, if you see what happens is there is a metabolic disorder with endocrine dysfunction. So there also it is also most of the time associated with obesity, and that is one common predisposing factor for endometrial cancer. Then there are familial syndromes which lead to early age of onset of endometrial cancer, and the most common is the Lynch syndrome. But the total percentage of patients with endometrial cancer having Lynch syndrome is again less, but this has to be kept in mind. And Cowden syndrome, where you have a P10 mutation, which also causes a lot of benign hematomas and as well as cancers in multiple sites, of which endometrium is one, also should be kept in mind. Now, a couple of words about endometrial hyperplasia, which is normally considered a precursor to carcinoma. And the older classification, it was put in the same way as that, because certain times some labs still continue reporting like that. So now we only have a hyperplasia and hyperplasia with atypia. These are the two things we know in the standard reporting. And if you see that hyperplasia with atypia generally has a higher risk of progression to endometrial cancer, and also in occult endometrial cancer can also be seen in about 30 to 45% of patients diagnosed with atypical hyperplasia of the endometrium. So when a hysterectomy or something is done, you find a associated malignancy in up to 45% of the patients. So since, as discussed earlier, there is mainly a disease affecting postmenopausal women, and only 3 to 5%, and this are under the age of 40, and this incidence is marginally high, rising now, but we are still not more than 10%. Now, for diagnosis, is a usual approach to diagnosis in any individual. The same approach is considered in endometrial cancer also. So, it's first is the history, and family history is basically to know whether any familial condition or familial malignancy has to be considered, like Lynch syndrome or Cowden syndrome. And next is the histological confirmation. So, in histological confirmation, you may have, generally what is done is an office people biopsy is done to confirm malignancy. Most of the time, that is enough to plan your treatment. But when you're considering sort of a fertility preservation, when you have in mind that you may not proceed with the surgery, it is always better to have a better assessment of the endometrium by dilatation and curettage, which may be blinded or it may be with a hysteroscopy. Now, generally, hysteroscopy is preferred whenever there is some focal lesions seen in the endometrium and which may be missed out by a DNC. Then you have the determination of the disease extent. Either the best option is a MRI or a transvaginal ultrasound. CT scan is usually not useful in determining the uterine extent. When I say about disease extent, because here what is the extent of the disease in the uterus? That is whether it is limited to the endometrium, whether it is infiltrating the myometrium, whether it is extending to the cervix. All this is seen better with a contrast enhanced MRI or even with a good transvaginal ultrasound, but a CT scan doesn't give all these things. Laparoscopy does not help because we are dealing with uterus confined disease, and only if imaging suggests any extrauterine disease, laparoscopy is there. So essentially, disease extent has to be determined by an MRI, and then you have to say MRI will also help us to know about the disease outside the uterus, any nodal involvement, either abdominal or pelvic, and then you should also have any imaging of the thorax. A simple X-ray would do also, or a CT scan to rule out any rare possibility of metastatic disease. The other thing is that it's always better to have a second opinion on the DNC because your entire treatment or entire approach depends on the definitive diagnosis or confirmation of a low grade disease. So you should always be sure it's always safer to get a second opinion. Secondly, nowadays endometrial cancer grading is done by a binary system, that is low grade and high grade. The low grade consists of grade 1 and 2 and high grade is grade 3. But when you are talking of fertility preservation, it is better to use the old grading system, that is grade 1, grade 2 and grade 3, because data till now available is for grade 1 tumors and there is limited evidence regarding grade 2 tumors. Now, coming to the specifics of fertility sparing treatment, now we have to fulfill certain criteria for fertility preservation. The most important, there should be a strong desire to preserve fertility. Age should be younger than 40 years. Generally, up to 35 years, the results are much better in terms of reproductive outcomes compared to 40 years, though the responses may be similar. A patient should be nulliparous or there is a desire for having more children for the family. Endometrial carcinoma grade 1 is the prerequisite. As I said, grade 2 we do not have enough of data as yet. Presence of progesterone receptor is an added thing, though it is not mandatory to check for progesterone receptor in all cases of grade 1. Serum CA-125 levels similarly indicate higher levels indicate occult metastasis, but that should be less than 35. But in presence of adequate imaging, this is also an additional factor. It's not a mandatory condition. So the disease essentially should be a clinical stage 1A, Olds 1A, with the absence of myometrial, cervical, or extrauterine spread. So there should be no myometrial invasion, no cervical invasion, and there should be no extrauterine spread. So imaging, as I said, for uterine factors, it should be a MRI or a transvaginal ultrasound, and extrauterine disease can be judged by other modalities also like a CT scan. And the other important thing is that they should be ready for a for a close follow-up or a close monitoring these patients. And another thing can be done right in the beginning. An opinion from a fertility consultant can be taken to understand what is the chances of whether they have any things which will cause problems in conception later. Now, what are the fertility sparing options? It's very simple. I'll just talk about the approach, then we go to the specific treatments. So, the rationale is treatment with progesterone works as they inhibit the estrogen receptors, leading to decrease in the endometrial mitosis, promotion of apoptosis, and then which results in the conversion to secretory endometrium. So, this is a broad thing in simple terms. And there are various fertility sparing options that essentially mean that the preservation of the uterus and with the reversal of the disease. And that is usually the basis of treatment is progesterone therapy. So it could be oral progesterone therapy or intrauterine progesterone therapy, and it could be combined with hysteroscopic resection of the focal lesions in the uterus. So this is a general approach, but you should also keep in mind high dose oral progesterones may have certain complications like increased risk of VTE, weight gain, mood and libido changes, headaches, breast tenderness, sleep disorders, and leg cramps. So many times the patients refuse to continue with high dose oral progesterone therapy because of these side effects, and then you have to consider alternative treatments. Now, hysteroscopic resection, what is it done basically is you can resect either a thickened endometrium entirely, or it can be done to resect the focal tumor lesions. And the advantage is it improves the accuracy of diagnosis, it reduces the tumor burden, and there is the evidence points to higher regression rates and shorter time to regression. That means that the number of months required for progesterone therapy is to achieve a complete response is less with a hysteroscopic resection of focal lesions or a large thickened endometrium is done prior to starting progesterones. But there are disadvantages also because you may end up doing more, destroying more endometrium, the basal layer, and the superficial myometrium, which may promote intrauterine adhesions and which may interfere with subsequent conception. So, as I mentioned, the relapse rate may be low when you have a hysteroscopic resection of a larger, thicker endometrium or focal lesions. This is the most important thing before you start. You have to have an informed consent, and here specifically you have to mention that the standard management of uterus removal with or without ovarian removal is the standard treatment, and anything other than that, there are risks involved, risk basically of disease progressing or disease recurring. And another thing which has to be clearly defined is that this is not a definitive treatment, it is a stopgap treatment. It only creates a time window to achieve a pregnancy, and it is not a long term solution of the disease. And the regular monitoring, as we stressed earlier, should be again talked about. And you should also say that the hysterectomy would be required after achieving the goal of fertility preservation or in cases where there is not a satisfactory response to the conservative treatment. Now, coming to progestins, the most common drugs used are medroxyprogesterone acetate and megestrol acetate. So these have similar actions, but megestrol has got more bioavailability when in the oral form compared to medroxyprogesterone acetate. But the complete response rates are similar, and certain literature shows advantage of one or the other over the recurrence rates and response rates, but overall it's not very different for both of these agents. So any of these agents could be the standard first line treatment. The other option is a progestin containing intrauterine devices which deliver a higher dose to the endometrium, and they have less systemic complications which are associated with oral progestin. And progestin IUDs, which are Mirena, can be used alone or combined with other drugs, which could be again progesterone or other drugs, which we will discuss. But one thing has to be remembered that we do not have any RCT data available to compare one modality or the other. So generally, these are cohort of patients who have received one treatment and or the other, and we see the overall response rates in each cohort and then compare the cohorts like that. But there is no one-to-one randomized clinical trial data available. Now, the dosage and duration of these are fairly standardized. They started with large ranges, but now medroxyprogesterone is effective with a dose of 400 to 600 milligram per day. Megestrol starting dose is 160 and could go on to 320. And when you're using a Mirena, that is levonorgestrel intrauterine device, which has 52 milligram, it is a slow releasing, and it can release effective levels of estrogen for 6 months to 1 year. Progesterone for 6 months to 1 year. And this levonorgestrel there are various ways of giving it. It can be given alone, but the overall experience is that they may have a lesser response rate compared to high dose oral, unless they are combined with either oral progesterone when it becomes much more effective. So you give oral medroxyprogesterone. Suppose, especially, you do not have to escalate the oral doses very high when you are combining it with intrauterine progesterones. Other option is if you cannot give oral progesterone too high because of side effects, you can add a GnRH agonist, which would again reduce the estrogen levels and help in the response rates. There would be certain conditions where a patient just refuses or is not suitable for progesterones. Then an option comes to give an GnRH agonist and give it along with an aromatase inhibitor like letrozole. So this also effectively reduces estrogens and helps in the regression of the tumors. Now, PCOD, like if you have this polycystic disease, they have a specific endocrine dysfunction, and hyperinsulinemia is one of them. So, in those cases, addition of metformin may also help in improving the response rates. Now, regarding the duration of treatment, the minimum duration is 3 months. So, if the disease persists at 3 months, at 3 months, the treatment can be extended. Because when you are monitoring, unless you find complete regression, you cannot plan to stop or reduce the drug. But the maximum time which you can give to conservative treatment generally is up to 15 months, because after that the regression is usually not seen. The risk of progression is higher. So if you do not find any response till that time, you have to go ahead and do the standard definitive treatment and surgery. So monitoring is to be done continuously. First monitoring is by symptoms. Usually these patients present with bleeding, episodes of bleeding, spotting, and then these generally reduce within the first 4 to 6 weeks. So the symptoms indicate that the response is happening, especially if there is no bleeding happening, no spotting happening. That means there is a regression occurring. So, in the absence of symptoms, you have to do the first pathologic evaluation after 3 months of starting progesterones. And if the patient is on oral progesterones, it's better to do a DNC to get adequate endometrium. But in those patients who have a Mirena, because the Mirena cannot be removed, it has to be there for the entire course of treatment. It will be expensive and it will be inconvenient also. So in those cases, in Mirena, you can do a pupil biopsy, because pupil can be introduced along with the Mirena in situ. So in those cases, pupil biopsy is good enough, provided you for patients following hormonal treatment is basically that it will have an adverse impact on future pregnancy by altering the endometrial status. And in the obese patient, weight management plays a very big role, because response and recurrences both are related to obesity or higher weight. Now, what are the predictors to hormone therapy? So, as I said, we have enough data to say that grade 1 is tumors, endometrial tumors respond better than grade 2 tumors. Similarly, thickness of endometrium, a lower thickness has a better response rate. So just to counter this, sometimes hysteroscopic resection is advised whenever you have a very thick endometrium. Molecular markers, progesterone and estrogen receptor status is always associated with a higher response rates. But other mutations, PIK3A and PTEN mutations have shown to enhance our hormonal sensitivity, but it is not, checking for these mutations is not recommended, because they generally do not have any effect on your further treatment. Absence of biometal invasion is the most important criteria, because superficial or non-invasive tumors have the highest success rate. Similarly, younger age, lower BMI, and absence of a metabolic syndrome also has a better response. So this is a good response population where you expect a shorter duration of therapy would be needed to achieve complete regression. So now we are talking of molecular typing of endometrial cancers, but the problem is that we do not have enough data to say that this affects the or adds anything to the prognostic value in this subset of patients. Pole mutated tumors generally have a favorable prognosis, and they may respond better to conservative management. MSI tumors again may respond, but they have a higher rate of recurrences. So these generally do not have a very good fertility outcome also. So you have to be cautious in this group. P53 abnormal tumors are very aggressive and they are not suitable for fertility preservation. And then generally it is not advised in this age group. But as I said, we have very limited data because P53 tumors are very less. That is under 20% of all endometrial cancers, and then this under 40 age group is again under 10%. So total number of cases in any cohort are very low to make some definitive conclusions. But no specific molecular profile cases, which are a big number. There is no difference in the standard fertility sparing protocols, and they have the outcome data similar. Now, surveillance after remission. So, this is remission would be when we have a complete response to treatment, and which is confirmed over 2 times. That I will again talk about it. So, we have to first ask about the history to see any symptoms are there. A physical examination. Generally, repair or a DNC or a cystoscopy, it should not be done unless you have an abnormality in symptoms or you have an abnormality in imaging. And now, generally, the statement is not accurate. Pregnancy is desired in all cases, so pregnancies could be attempted. So the question is, if there is, if the fertility specialist feels that the patient can have a spontaneous conception, you can give time for a spontaneous conception. Generally, up to 6 months is given, but you should not have a very long period where they don't conceive. So there, artificial reproductive techniques, IVF, etc., should be attempted. In certain cases, these girls may not be married also. So in those cases, there is a delay in pregnancy. Then you have to consider protecting the endometrium with a combined oral contraceptive pills, which are a combination of estrogen and progesterone, or low dose cyclical progesterone to avoid hypertrophy of the endometrium, or the Mirena could be continued. So these options are there when you don't expect a pregnancy happening in the next 6 to 9 months. And then completion surgery has to be done at the end of childbearing. Now, how do you assess response confirmation? By this, I mean that the patient has had a complete reversal of the pre-malignant or the malignant process. So you should have 2 consecutive complete response endometrial biopsies with a minimal interval of 3 months are necessary. So this is necessary that supposing you have started your progesterones on day 0, at the 3 months you do a biopsy and it shows no residual disease. You continue the progesterone for the next 3 months and then do again a biopsy, which again shows no residual disease. So at that state, it is considered a complete remission, and the patient would have received 6 months of treatment. If you have a disease persistent at 3 months, then you do one at 6 months, and then you do one at 9 months. If 6 and 9 are negative, then you say the patient has had a complete response, and the duration of treatment would have been 9 months. So this is very important, that you should have 2 biopsies at 3 month interval, which showing no residual disease to confirm a complete response, and then only you can recommend pregnancy. So as I mentioned, artificial reproductive techniques shorten the time to conception, avoids prolonged unopposed estrogen, which results in oncological safety, and risk of relapse and disease progression are reduced. So this is an important issue in defining complete response. Now, what are the recurrences after fertility sparing treatment? So again, as I said, we have studies, independent cohorts and all that, and all these meta-analysis will say that the responses generally are in excess of 70%. The relapse rate is anywhere between 30 to 45%. And the death rates are quite low because they are picked up early and they are treated early. If a recurrent disease is diagnosed during the follow-up, and if the patient is still very keen on fertility preservation, a second attempt could be done, and you may have a similar response rate. You start the whole process again. You again put them back on the same protocol which we discussed, but the response rates may be lower and recurrence rates may be higher, but it is there. That option should be, or rather can be considered if a patient requests, even if there is a response following fertility sparing treatment and the pregnancy has not happened till then. So as I said, recurrences follow-up, we don't have enough data, so mortality rate, we cannot be very sure that it is whatever is documented is there. Now, reproductive outcome, again, is that, as I said, over 76% regress, and the live birth rate is around 28, and that is also a range now. If you consider all advances in ART, it is 28 to 35% have live birth rate. But this also depends on the baseline condition. So, as mentioned earlier, spontaneous conception should be judgment of the fertility specialist, and those who have a patient who have a history of ovulation and fertility problems should straight away be put on IVF or a similar procedure. So as seen in most of the studies, ART or IVF had a higher live birth rate compared with those who tried spontaneous conception, because many of those would have had inherent problems in fertility. And IRT, the argument used to be that you induce a hyperestrogenic state for inducing ovulation, but that did not worsen the relapse rate. Moreover, now you are protecting against hyperestrogenism by adding a aromatase inhibitor during their ovulation induction. Now, what are the prognostic indicators for a reproductive outcome? So this is now you have a patient who has responded completely to your treatment and is now disease free. Now the goal of the treatment was that the patient have a successful pregnancy. So, but there are certain indicators which will guide you to help you know whether this approach has been successful in preserving the reproductive function. So the most important is the ovarian function at baseline. That's why a fertility specialist consultation is important. There are no standard or accurate measures of ovarian function, but what generally is done, there are two, three things which are usually seen. One is the anti-Mullerian hormone levels, AMH levels, which should be in the normal range, or you can have a antral follicle count done by vaginal ultrasound. If you see enough of follicles, that means this patient or this woman has the potential of getting mature oocytes at ovarian stimulation. And sometimes even the early menstrual period, that is between day 2 and day 5, the FSH levels, if they show enough, that they show a good endometrial preparations in those patients also, fertility may not be compromised. So these are all indirect indicators of ovarian function. There are no standardized things, so the judgment is left to the fertility specialist. The second is the age. Age, as I mentioned once earlier, that age less than 35, the live birth rate is higher than the when the age is between 35 and 40. Some of the series have shown a difference of about 5 to 6%, like 31% has been quoted for age plus up to 35 live birth rate, whereas for above 35, 40 years, it is falls down to 22 to 24%. Similarly, obesity. So obesity, as mentioned, has a negative effect on the fertility, also on conception, also on the time to pregnancy and the pregnancy outcome. So all these are affected by obesity. So that means you may need a longer time of treatment. Even after treatment, the conception may not happen. And the fertility outcomes also, there may be more pregnancy complications and pregnancy loss in obese patients. PCOS, polycystic disease, again, it is an endocrine system disorder and associated. They may have a diminished response to oral progestins, and in these cases, maybe certain cases, as I mentioned, metformin addition helps. Now, Lynch syndrome, there is generally still in an exploratory phase, rather that there is no consensus on the suitability of fertility sparing in these patients because uh, it's associated with a younger age and there's a risk of an associated ovarian cancer also, and a resistance to hormone therapy is seen in this group of patients and recurrences are more common. So in this, you have to really counsel a patient and say that there are a lot of limitations with your conservative management, and if the patient really understands and wants to have a one try, it could be considered with risk. Now, gray areas which we still face are if a patient presents to us with grade 2 or with some myometal invasion, because the standard guidelines say there should be no myometal invasion and the tumor should be only grade 1. But certain we have some experience now with grade 2 tumors also, but they have a receptor positive grade 2 tumors with superficial myometal invasion. They also show good responses, but have a higher relapse rate. And again, as I said, the numbers are not too much to give general recommendations. But again, this has to be discussed with the patient, and it all depends on the acceptance of risk and the desire for fertility. So you have to balance all that and decide whether you include such patients in your treatment. Then whether we should retreat patients with a relapse who have not had a successful pregnancy. As I mentioned, this option could be given because response rates are seen, but you have a very high relapse rates also. So you may essentially get a very small window to attempt a pregnancy again. Now, surgery, definitive surgical treatment is hysterectomy, bilateral oophorectomy, and staging. And you have to do it after completion of childbearing due to a high recurrence rate. The case is that if you have a complete response to treatment, that is two biopsies have shown negative, and then you had a normal childbearing, and there is no disease after that. A completion surgery need not include lymph node assessment. It could be just a via hysterectomy. And in cases of recurrence or no response at 6 to 12 months of hormonal treatment, as well as in cases of disease progression, you have to do a standard surgical approach, that is a hysterectomy along with surgical staging. Now, to summarize all these fertility sparing treatment indications, as I mentioned, well differentiated endometrioid carcinoma, selected cases of grade 2 with risk, with minimal myometal invasion. There should be a strong fertility desire. So anything above no myometal invasion is with risk. So that has to be explained very clearly. Receptor study, as I said, is useful, and especially in grade 2 and myometal invasion cases, to know whether this should be taken up. MRI as an assessment tool is mandatory to rule out invasion. Then options we have already discussed: oral high-dose progesterone, whether intrauterine progesterone plus GnRH analog, and then completion surgery after childbearing. So this is a snapshot of the fertility sparing treatment which can be offered. Now coming to the second aspect, that is ovarian preservation and primary surgery. So the rationale is that early disease has more than 90% 5-year survival, that is grade 1 tumors, stage 1A. There is a very low incidence of ovarian metastasis. Menopausal symptoms could be severe in this age group. And in other things is that maintenance of hormone function has a positive impact on the cardiovascular, bone, and CNS health, and generally that is associated with a better quality of life. What they are simulated, there are concerns related to ovarian preservation. One is missing out occult metastasis or synchronous primary ovarian cancer. and usually the incidence is very low in the absence of extrauterine disease. So even only you have extrauterine disease, you have this ovarian metastasis. Then there may be a risk of relapse of hormone sensitive endometrial primary. This is a logical relation or a theoretical relation, but it is not seen in the population. So, but on the other hand, don't have prospective clinical trials to say that it is absolutely safe. Also, we have certain cohort studies like this one cohort study I've quoted, which did not show any increase in the relapse rate or mortality by preserving ovaries. So, how do we decide whether to keep or preserve or remove the ovary? Is basically patient's age. So, generally, in this population, is we are younger patients, so age is considered suitable. Probability of ovarian involvement. It would again in grade 1 tumors, it is very low unless you see an obvious extrauterine spread. Genetical and familial high risk of primary ovarian cancer. That is one thing you have to keep in mind. They should not have a genetic disposition to have an ovarian malignancy. Presence of adnexal disease is absolutely the obvious contraindication. And even if you do an ovarian preservation, salpingectomy is recommended, like a standard which is there now for all oophorectomies now. So again, to summarize this ovarian preservation, again it is individualized. The patient has to understand because essentially it is because of the limited data available. The patient has to be explained the risk. Genetic test has to be done for a family history. Not suitable if you find any disease outside the uterus inside pre-operative, intraoperative assessment. But these patients you will not be taking up for your fertility preservation management. And intraoperative assessment is also necessary, that you have to visually inspect the ovary properly. It's not a biopsy, but careful visual inspection is mandatory for preservation of the ovary. Now, the last part, is there any role of hormone replacement therapy? So generally, hormone replacement therapy is only now in the current context with these patients is only to manage excessive estrogen withdrawal symptoms. So postmenopausal symptoms of flushing and any emotional disturbances and all. If they're excessive symptoms, those are the candidates who could be considered for hormone replacement therapy. So again, for this, there is insufficient high quality evidence to say for or against. But there are some non-randomized evidence which does not suggest significant harm if it is used after surgical treatment for early stage endometrial cancer. The use of again, it is stressed that it should be individualized, basically taking into account the woman's symptoms. The severity of the symptom is the one which decides the need for hormone therapy, not as a general measure to improve the health sort of a thing, but only to treat specific symptoms. And you have to consider the molecular subtype and the recurrence risk. If there's a higher chance of a recurrence, better not add anything which is not known. So if you decide on hormone replacement therapy, it could be estrogen alone, which could be either oral or intravaginal. That is usually recommended, not in this population, because it is usually recommended for those cases where the uterus is not there. For this patient, in our group, we are preserving the uterus, so you have to give a low dose estrogen progesterone combination, which is there which will take care of the symptoms. So that is, in a nutshell, basic approach to this specific group of population. Yeah, Dr. Somsekhar? Yes. Any Yeah, how do I see the chat box? Okay, chat.
At bottom there is option to chat.
Yeah, I saw that now. But I don't see any messages there.
Yes, sir.
No, somebody has put a question whether there's any, according to recent staging, is there any changes in management? See, we are not going here by stage in this, as I said, we are going by specific criteria, that is no myometrial invasion, grade 1 tumors. So these are the general criteria we are following. We are not following any other staging system in this case. What is the other question? Tumor size 2 centimeters criterion for fertility preservation, as large tumor respond less and even no, we don't take tumor size as a contraindication now, but we have to keep in mind that a hysteroscopic resection helps. The main criteria are again, as I said, there should be no involvement of the cervix, there should be no infiltration of the myometrium, and there should be no higher grade. A size is not a contraindication on its own. Mirena acts as a contraception. How can the patient achieve fertility with treatment? See, as Mirena is a treatment till we are giving treatment. As I said, we give a treatment, we assess at 3 months. And again, we assess complete regression seen, then we assess again at 6 months. And if it's complete regression, we declare a cure and remove the Mirena. If there is still persistent disease, we may have to go on till we get 2 negative 3 monthly biopsies, and maximum we can go on is till 15 months, and then after that Mirena is removed. Only in those women who are not likely to get pregnant, like those who are not married or who have some other reason they will not get pregnant in the next 6 months, we continue with the Mirena. But once this is over, we remove the Mirena and then give a chance for pregnancy. Now, is molecular testing before fertility preservation mandatory? Now, molecular testing has become mandatory for all endometrial cancers. So, as a part of that protocol, it is being done. But influence on fertility preservation is still not defined. So, if you have a grade 1 tumor, if you have P53 and then you have negative, you may do ERPR in those cases. And if there is negative, obviously, you will say that this patient is less likely to respond, and you will not encourage fertility preservation in that. But molecular testing is now becoming a norm, standard approach for all endometrial cancers. If there is a role of, what is the one question is, what is the role of laparoscopic evaluation for extrauterine disease before starting therapy? Normally, if your imaging is negative, you don't need any laparoscopic evaluation. Only if there is a suspicion that they may or may not be disease, then you need to do a laparoscopic evaluation. But generally, imaging gives you all the information, because even if there's an ovarian enlargement on one side, you may not get any additional information on laparoscopy, but rather than by MRI, which will tell you the nature of the tumor and which will give you an ORAD score whether it is likely to be malignant or not. So, laparoscopy, this select population having very limited disease, no myometrial invasion, is generally does not give any other useful information. Only if you have suspicion on imaging, you have to do that. Yeah, role of combining bariatric surgery with fertility sparing treatment. Yes, this has a role because obesity above 30 BMI generally does not, those patients need longer treatment, have a higher relapse rate. So weight management becomes crucial in them to improve the response rate. So it could be done. Bariatric surgery or any other effective weight management technique would be certainly useful in those group of patients. If a woman is already pregnant first trimester, no myometrial invasion, how do you manage? We normally don't. How do you know there is a disease there when the woman is pregnant? You will the endometrium assessment during pregnancy is not there, and generally the hormone levels in the native progesterone levels increase so much in the early pregnancy, they would even reverse any hyperplasia which was pre-existing before the pregnancy. So you don't interfere anywhere in these cases unless you have a defined tumor seen. Then you have to think what to do because tumors may not be a endometrial carcinoma. It could be some sarcoma or something. So that is a different issue. But generally, endometrial patients who had a previous diagnosis of atypical hyperplasia or a well-differentiated endocarcinoma get pregnant, then you can just watch because their inherent hormones itself would lead to less chances of progression. Yeah, metformin in weight management is a question I've already mentioned. It's usually helpful in PCOS cases. Who have PCOS also, those cases metformin would help because it takes care of the endocrine disorder associated abnormalities, metabolic abnormalities in those cases. But in general, there's not much experience with metformin and weight management. If first two biopsies after Mirena and Megestrol show no regression, do we continue the same or give the option of hysterectomy? See, as I said, if your first line could be Mirena with a oral progesterone, 160. You could give the next cycle with a higher dose of oral progesterone if they tolerate, or you can add a GnRH analog there instead of a progesterone and see for the next 3 months. And if with this higher dose of progesterone or a GnRH analog is not helping, is not aggressing, as I said, we can continue for a maximum of 12 months. 9 to 12 months is the maximum duration of treatment for this. Only in those cases who show a regression but not a complete response do we extend till 15 months. But generally, if they do not respond by 9 months, they generally do not respond. So you have to be always be open for a definitive treatment. Does atypical hyperplasia also need hysterectomy cure? The atypical hyperplasia, if it has been confirmed by hysteroscopic DNC and there was no invasive cancer, then that does not usually require hysterectomy after KO. I think these are all the questions now. Thank you very much for a patient hearing, and I hope I have answered most of the questions which you had in your mind. Thank you very much.
Can I conclude? Dr. Vijay, sir? Dr.
Can I leave now?
Okay, thank you. Thank you everyone for joining this session.
Yeah, thank you. Bye.